All right, let's get straight into it. If you're prepping for your final exams, this is for you. We're diving into a supercritical, high-stakes scenario, how to manage a cardiac arrest in a patient who's just come out of cardiac surgery.
So what's on the menu today? First, we're going to break down why this is a totally different beast than your standard cardiac arrest. Then, we'll nail down the reversible causes you have to know. We'll walk through the specific protocol for this situation called CALS, and finally, we'll see how the team puts it all together.
Right, let's kick things off with the absolute most important thing you need to get your head around. A cardiac arrest after cardiac surgery is not, I repeat, not the same as your typical arrest. And if you treat it the same, you could do some serious harm.
Now, get a load of this number, 79%. That's the survival rate we're talking about for these specific arrests. Compare that to maybe 18% for other in-hospital arrests. So what's the deal? Why such a massive difference? It's because the causes here are almost always fixable.
And this right here is so important. Your standard ACLS muscle memory, it could actually be lethal to your patient here. I mean, think about it. Hammering on a chest that was just cracked open? No way. The whole playbook is flipped on its head. The priority is finding what's wrong, using stacked shocks, and getting ready to reopen the chest.
Okay, so if the causes are reversible, what are they? Let's dive into the usual suspects. For your exam, being able to run through this differential in your head, and fast, is absolutely key.
First up, hypovolumelia. Basically, the patient is bleeding. Now, this could be a medical bleed, a clotting problem, or a surgical bleed, where a stitch is popped. A chest drain that's just pouring out blood is a huge clue, but be careful, you can have a hidden collection of blood building up even if the drain output is low.
Next on the list is something called low cardiac output state, or LCOS. You can just think of it as pump failure. After being on the heart-lung machine, the heart muscle can get, well, a bit stunned and swollen. It just doesn't pump as well for a while, and it needs support to get through it.
And that brings us to the one that strikes fear into everyone's hearts: cardiac tamponade. This is where blood gets trapped in the sac around the heart and literally starts to strangle it. It's a purely mechanical problem, and it needs a surgeon, like yesterday.
Okay, write this down, highlight it, tattoo it on your brain for the exam. Forget the classic textbook signs of tamponade. A patient can look fine 1 minute and then suddenly arrest. That arrest might be the first and only sign you get. This slide just shows you why it's so tricky to spot. Look at the image on the left. That's a transesophageal echo, a TOE. You can clearly see the heart getting squished. Now look at the right. That's a transthoracic echo. With a fresh post-op chest, well, it's a mess. You can't see much at all. The TOE is way better here. But, and this is the crucial part, tamponade is a clinical diagnosis. This quote says it all. Even if your fancy echo is negative, if the patient is crashing and your gut says it's tamponade, you go back to the operating room. Period. You trust your clinical judgment over the picture. All right, we've covered the what and the why. Now let's get into the how. This is the Cardiac Advanced Life Support Protocol, or CALS. You absolutely have to know this algorithm inside and out. So let's kick it off with a classic exam scenario. Your post-op patient goes into VF. According to CALS, what is the very first thing you do? And the answer is 3 stacked shocks. Boom, boom, boom. You deliver them one right after the other before you even think about starting chest compressions. Why? Because VF here is often easily reversible. If that doesn't work, then you give amiodarone and scream for the resternotomy trolley. Compressions only start after all that has failed. This algorithm is your roadmap. Just look at it. No matter where you start, VF, asystole, PEA, see how all roads lead to that one box? Prepare for emergency resternotomy. That's your ultimate safety net. And it's all about the 5-minute rule. You've got 5 minutes from the start of the arrest to get that heart beating again. If your initial steps don't work, the chest has to be reopened. It's the only way to get your hands on the heart, defibrillate it directly, and instantly fix a tamponade.
Okay, so that's the theory. Let's talk about putting it into practice. We'll look at how the team works together and cover some special cases that you'll definitely be asked about.
A smooth CALS call is like watching a pit crew in a Formula One race. It's choreographed chaos. Everyone knows their job. You've got the team leader running the show, someone on the defibrillator, someone else grabbing that resternotomy trolley. This diagram shows you all the key players.
Okay, here's another exam question for you. Adrenaline, right? It's the star player in a normal resuscitation. So why do we actively avoid the standard 1 mg dose here?
Because in this situation, it is so dangerous. Imagine you give a big whack of adrenaline. You get the heart back, and the blood pressure shoots through the roof. You can literally blow a brand new bypass graft right off the aorta. That means catastrophic bleeding, and you're right back where you started.
And don't forget about the gizmos. If the patient has pacing wires in and they're in asystole, your first move is to crank up the pacer. Got an intra-aortic balloon pump? You need to switch its trigger from the ECG to the pressure waveform. Otherwise, it's useless during compressions.
So if you remember nothing else, remember these 3 things for your revision. 1. Stack chocks first for VF. 2. Get ready for a resternotomy within 5 minutes. And 3. No adrenaline. Got it? Those are the game changers. All right, let's leave you with one to chew on. Your patient is 12 days post-op. They're on the ward, not the ICU. They arrest. Now what? Do you try to rush them back to the theater, or do you crack their chest open right there on the ward? It's a tough call because by now, everything's starting to get sticky in there, making it a much riskier procedure.
Everything we've covered today comes from a fantastic review article in BJA Education from 2018. It's well worth a read. Okay, that's it from us. Good luck with those exams.